31 participants and growing.
Okay. Well, I think I'll start with an introduction. Good evening, everyone. David Dennison. It's a pleasure to begin our series tonight on distal ulnar fractures. We have hopefully a nice fun hour or so for you to go through some distal ulnar fractures. I'd like to thank Marco Rizzo for all of his efforts, and everyone at the AO for working on getting all these sessions together and managing everything. It's a tremendous amount of work. We appreciate everyone's help. Tonight, joining me is Tom Fischer and Chelsea Boe and Rachel Pigott. Hopefully between Tom's sage advice and Chelsea's going to teach us a lot about distal ulnar fractures and how to manage them, and some tricky things that she's learned and will show with us as well. And then Rachel will show us how to make sure everybody has a perfect outcome, hopefully with some therapy. These are our disclosures for all of the faculty and chairman for Marco. Just to remember that AO is an independent nonprofit surgical specialty. It doesn't specifically endorse or promote any products, and the equipment used in this course is for demonstration and teaching purposes to help with the learning experience. CME credit is available for the session. If you look down here, there will be a link at 24 hours that you can use for your questionnaire and to claim your credit. All microphones are off, so we won't be able to hear you. If you have questions, please send them through the question and answer box. We'll do our best to monitor that and answer as time allows. And the chat box will be just for the faculty, so question and answer box is the main thing for everyone in the audience. Our agenda will begin with some introduction that I'm doing now, followed by a case 1, 2, and 3 series, essentially talk about some therapy, and we'll come back to a few highlights and case discussion a little after the hour. The objectives are here, hopefully that everyone can identify these the indications for some of the procedures, and also when not to operate, the non-surgical indications essentially. Identify and understand the clinical criteria for the indication of the procedures, appropriate surgical anatomy and steps we'll cover quite a bit, and also talk about some pitfalls and strategies to avoid them. And then we'll throw in the literature as time allows as well. Just a reminder where we are in the year, up to distal ulnar fractures now. And then we have a few left for the rest of the year in September, October, November, December. So keep an eye on your emails so you can participate. We have some other webinars coming up August 7th on both bone forearm fractures, and then December 4th for distal radius malunion. These webinars are free, run from 8 to 9 Eastern time. And these are the upcoming AO trauma hand NA courses. In particular, the one coming up we're excited about in a few weeks is out in San Diego for the hand fellow and chief resident course. Also, you can access these recordings through YouTube AO Hand North America, and this is also available on OrthoTV online as basically a streaming channel. Hopefully you're all on the Zoom channel, most likely. And with that, I'm going to work on stopping my sharing and moving over to one other talk. Excuse me. Sorry, guys, you can't see that, can you? Okay. Can you guys see that now? Sorry, Tom.
Yeah, good.
Finally. Sorry about that, everybody. Okay, so David Dennison, I'm going to start with distal ulnar fractures, a little bit more of a summary, and then turn it over to Tom. But basically what we want to do for this hour is to provide a basis for the initial evaluation and treatment of acute fractures of the distal ulna or the ulnar side of the wrist, essentially. Each case is different, anything from a Galeazzi here to a distal ulnar fracture, and the principles are really the key. I think the main things to consider, though we're going to talk about the distal ulnar fracture or distal ulnar fractures, that we do have to respect and understand there is always a soft tissue injury, such as ligaments or the TFCC, ulnar styloid, or the distal ulna. Just a little bit of anatomy here, but just it is kind of an interesting bone with all the little nooks and crannies here as far as the styloid, the fovea, basically the pole of the distal ulna that will go under the TFCC, and then the seat which faces the sigmoid notch, and also the sulcus for the ECU groove, a small space that we'll hear more about from Tom as well. And Dr. Berger always had great pictures to share with us about the TFCC and the DRHA and how this space is, but also keep in mind the shape of the ulna as we're talking about potentially putting some things in the ulna, sort of this teardrop-ish shape, the capsule. Things are close by, sensory branch ulnar nerve, not a lot of room, but just it's good to have a good ability to visualize the geometry here, and then factor in that it's broken and you're trying to figure out where your screws are going. The DRJ again is a combination of balance of bone and soft tissue for stability and motion. Injury to these structures are very common. But if we can line them up pretty well and keep them there, a lot of them will heal quite nicely. So the goals are to identify injuries to the DRJ and to detect that instability when it's present, with or without a fracture, and then to treat that instability along with stabilizing the fractures. So I'm going to jump in with a little bit about this. Most of this, the interest in coronal plane correction for distal radius fractures has been pretty clear. It's been really, I think, something we've talked about a lot in the last 10 years, especially after we all got over the rage of, I should say the volar plating was great. And then we're like, well, we can do a little better. We should probably be looking at coronal plane correction a little bit better. And there may or may not be a distal oblique bundle here in everybody, but nonetheless, correcting the anatomy and tensioning the soft tissues is still a pretty good idea. These are just this is Scott Wolf's paper just showing that this is probably present, maybe not in everybody, but nonetheless, you may as well try to correct the fractures anatomically as possible. Just a quick lip service. I'm a metaphyseal lifter to try to get this reduction, but whatever you do to get your coronal plane reduction of the radius, the idea is to restore the tension to the IOL and the soft tissue. And that also puts the TFC and the styloid hopefully back close to one another where they belong, that is on the distal ulna. And if you look at that, the history of ulnar head and neck fractures in the previous time when we didn't necessarily fix them all, there was a little higher rate of radial fracture non-union. For example, if you tried to cast the two bones, or there might be some limited rotation or synostosis. That's a bit more rare these days to see ulnar or radial non-union with an ulnar neck fracture, probably unless you operate on it, especially with ORF of the distal radius, because we have pretty good stability of the distal radius with that. So just to kind of get the discussion about styloids through, tip fractures rarely require treatment, but don't be fooled by the absence of a styloid fracture. You have to check the DRJ for stability just as much with a fracture as without. It used to be thought that the basilar oblique fractures that were larger and displaced would be a problem. I think probably because we didn't have as good a fixation of the distal radius, frankly. But if you look at the data going forward, looking at all the volar plating, most of these on the right have been volar plating reports, that the outcomes were really quite good. And the data would suggest you probably don't need to do anything with the styloid fracture alone unless there's DRJ instability. Or if it's in, there can be rare cases where it can even be in the DRJ or something like that. But for all comers, for the basic distal radius with a styloid fracture, most of us are comfortable with treating the fracture or the treating the ulnar styloid fracture or the TFCC injury only if there's associated instability of the DRJ after ORF of the distal radius. It's a little bit less common that you're going to see that in the setting of a radius that's not broken, but similar rules. So just to kind of jump by the styloid fractures. So here's an example, just a quick case. I did this a while ago where I was like, well, I've just reviewed all the literature and it says I'm good. I didn't feel any instability. And then sure enough, about 4 weeks after we getting her going out of a splint, and she's having trouble supinating, not that much pain, but just really can't supinate. And that's not all that uncommon actually, right? But just seemed a little bit off. And you can see I probably overstudied this one, but her TFCC is probably where you'd expect it to be. It's not too far away, but she's got a instability in the sigmoid notch in the distal ulnas, dorsal relative to the radius. So this needed a little bit of help, and we were able to go back and provide a styloid and TFC repair and try to get this back on track. So watch out for them. they can happen. But if you do have pretty good stability, I think you're good with I like a neutral splint for a few weeks if necessary. But if you're going to fix the styloid, there's lots of ways to do it. We won't have an exhaustive list here, but just make sure that if you can't seem to get the styloid where it belongs, probably look at the radius and make sure that you're not off there. You can choose however you like to do it. I've kind of gone away from wires. Dr. Berger taught me that if you use a wire, eventually it breaks, and then you're explaining that to patients. So a 2-0 sliding knot is pretty on a Vicryl or Ethibond is pretty nice, and you don't have to look at it. But you can use a tension band. You can use as much as your imagination allows. I would say please make sure that you find the sensory branch and protect it. Ulnar side is great for exposure. For styloids, again, you can use any type of device you're happy with. Try to keep it low profile, of course, and we'll hear more about that from Tom as well. Moving into the distal ulnar fractures, whether they're articular or comminuted and what level they are in the distal portion of the ulna, we certainly can see quite a bit of a spectrum of this particular injury, comminution, displacement. These are just a few cases I chose to show here, but in general, from what we saw with the styloid fractures, if we can get the radius to be well aligned and provide stability there, a lot of these ulnas can heal on their own, just with a little bit of displacement perhaps, but patients have good rotation. For me, it's 3 to 4 weeks in a neutral rotation splint, sugar tongue, or I've kind of gone away from a sugar tongue, but at least something that limits their rotation a bit. And then once they're feeling pretty good, we get them rolling kind of in 30-30, 45-45, and then they can go on their own once they reach that. If it's something where you fix the radius and you feel that dreaded crunch or you can't rotate them, you have to look, and you may be going in to fix the distal ulna or to stabilize it if it's more displaced. We don't have great numbers for this. Tom's going to talk about some ideas, but it's really more of a little bit of a gestalt about if you can't have the DRJ rotating very nicely, then you probably should be thinking about maybe fixing the ulna or at least reducing it some way to restore that forearm rotation. This is one way you might do it if the skin isn't so great. Sometimes simple works very nicely. If you have to use K-wires, you might get fancy with them if you need to, but you have to deal with pin sites perhaps, so burying them might be nicer. So you have to, none of us really like that, I don't think. We try to bury them if we can, but keep in mind that sometimes making it a little better and maintaining stability might be enough for these. In the history of fixing these, the implants weren't the best. They got a little better. You can see some of these from, this paper is actually only 2004. But we do have a little bit smaller implants that are available now, and we'll talk about some places to put them and maybe not put them and try to put them in good places to provide stability but not aggravate the wrist too much or the sensory branch or the ulnar nerve. But this can also help preserve the stability, the space between the radius and the ulna, or as we talked about, coronal plane correction again. Just a couple of cases here. So here, volar plating, as well as this was an old case I did in X-Fix and pins, if you can imagine. Healed great, not too big of a deal, 3 to 4 weeks of a splint. Funny story with this lady, she insisted that all this had to be off for her trip to Vegas. So that came off in time. She was able to play the slots. I think she won enough that she came back happy. But, again, this healed great on its own. I was fortunate not to get overzealous about trying to cause a different problem for her despite all those pins. That was the X-Fix, bone graft, and pins, if you can imagine. Good old school stuff. Here's another case, 68-year-old lady who, pretty good fracture, not too bad. We start by looking at the radius reduction. It's pretty good. It's a little bit comminuted. Pretty good alignment. A little worried it's a little ulnar positive, but so far so good. Complete healing in, really short period of time, 4 to 6 weeks. It looks great. Heals faster than the TFCC. So, I really credit Dave Ring with helping us get along with trying to fix these and what's the next implant. You can see that that's going on some other things. With some time later, I'll come back to a case or two. But I think that when you have a displaced distal ulna, that fixing it is reasonable, that you don't have to fix every one of them. But if you really can't be certain about the stability of the ulnar head so that you can rotate the radius on it, I think you should be thinking about it. You can, again, choose what you like. These small plates have been something I like when I need them. And again, protect that sensory branch as best you can. This is just a little sketch I like to show about, the radius. We all know how to correct the coronal plane of the radius. But again, the ulna, sometimes it's tricky. You need to almost pull the shaft out in a way to get it to reduce. And an ulnar plate, or technically a pusher, that can be helpful, can be a little bit prominent. So you want to be careful with it. But for example, in this case, this is comminuted, and I didn't really like how this was just kind of mushing around when I tried to check the DRJ stability as well as rotation. So we went ahead with fixing the radius and getting a pretty good alignment. I think we backed that pin out a little bit when we were done, but we went ahead with just a provisional fixation enough to get a plate on, and here we are restoring that. But for example, in this case, this is comminuted, and I didn't really like how this was just kind of mushing around when I tried to check the DRJ stability as well as rotation. So we went ahead with fixing the radius, getting a and make it work for these. So with that, the only other thing I was going to add is if you think you have an articular fracture you're going to have to go after, I would say think twice, because often those are pretty powdered in there and you may or may not want to be trying to fish around for them. But if you do, make sure that you use that incision dorsally as you go distal so you can get to the joint, and then you can expose it along the ulnar side, or even wrap around the ulna if you have to, palmarly. But consider that, before you go too far down the stylet. If you make it long enough, you'll get there anyway, but sometimes a nice little curve can be nice if you think you have to get up there, or if you think you might be dealing with any form of a TFC repair afterwards as well. These are guidelines, the amount of step off or length or angulation, but I think it's really more about the stability of the form, and if you think that's going to be okay for the next few weeks. If you should get into a really bad one, or it's destroyed, dog bite, something else, or it's open, there may be a role for acute debridement. I'm not a big fan of that as far as taking the distal ulna out, but you have to consider that. And implants and fusion acutely, we'll see them. Some people will present those. I would say try to keep it simple for the first round, in my opinion, and you can always deal with something later if you have to. The only other thing I'd say is occasionally if the radius is really bad, it can be a good bone graft, but hopefully you don't have that bad of a case to start with. So with that, I'm going to turn it over to Tom, who's going to kind of take all that and go into more detail about some great points about how and when to fix these fractures, and then some things about how to do it. So I'm going to stop sharing and appreciate your time, Tom. Thanks for getting everything together for this talk.
Super, Dave. That's a really good introduction, and see if I can get this rolling here. All right, does that look right to you?
Looks great.
Thank you. This yeah, there you go. This area we're talking about is really a small piece of real estate. It's really the area distal to the central band insertion on the ulna, that little place where the ulna is prominent and takes a about 11-degree jog sometimes. The DOB, or the distal oblique band, is highly variable, and we've learned more and more about it in the last 10 years. I suggest you look at Moritomo. He's out of Osaka, and has a great discussion on the anatomy of the forearm and the variability of this. The AO defines the distal ulna and distal radius with this box that's as wide as it is long, and so it's a square that. But I would extend that box a little more proximally to the insertion of the DO, or the central band, which is right at the proximal end of the pronator. There's a vessel right there, and it's where I do all my ulnar shortenings also. But the piece of real estate we're talking about is from that point on distally out onto the TFCC. And Dave has shown us some very nice anatomy of the TFCC. I also think that the columnar theory of the distal radius is espoused by Rickley and Regazzoni is really helpful for me to understand what I'm dealing with in these complex injuries. And for today's discussion, I think we need to talk about having the radial column and the intermediate column as anatomically correct as possible. We'll go over some of those parameters, and that the rest of the forearm is in stable condition. And the distal ulna fractures are really what we're talking about. And they've been categorized in the last few years through the AO with a classification system. All of this has evolved significantly since we started fixing distal radius fractures in the 90s. I mean, Dave showed you external fixator with pins. That's what I did in my residency at Harborview 40 years ago. So we still use external fixators today. We just put them on the surface of the bone as locking plates. And so I think it's a common fracture if you include styloids. The very young and the very old have significant involvement of the distal radius sometimes with distal both bone forearms, and then osteopenic problems of fractures of insufficiency that accompany many distal radius fractures in osteopenic patients. I really think we need to look at our surgical indications more by demand than more by the x-ray appearance, as I really don't have a good set of x-ray parameters to give you great idea of what should be fixed and what should not be fixed. So it goes down for me a little bit of gestalt, and it also goes down to the fact that we look at instability at the end of the fixation for the distal radius. And so the restoration anatomy is what I always fall back to. I've always been a kind of a fracture surgeon, and the restoration anatomy seems right to me, and the fact that it's evolved over, a million years or so. So this classification system can be found in the AO manuals and the AO surgery review. And we're really not talking too much about B's and C's there, but the D's and F's are the ones, and the articular zone fractures, the head splitting type fractures. The distal ulna is not unlike the proximal humerus, and the fact that you've got the ECU tendon looks a lot like the biceps tendon. The offset of the glenoid is a lot like the sigmoid notch offset. The offset of the proximal or the distal ulna is a lot like the offset of the proximal humerus. So the greater tuberosity ends up being the styloid. And so if you take the basic principles of the proximal humerus and apply them to the ulna and put your plates on where they can not disturb the anatomy, then you're in pretty good shape. Most of these are always shown with the dorsal groove of the ECU, which I try to avoid, as it is an amazing piece of integration in the distal ulna. So I try not to destabilize that. I'm a big volar approach guy. Dick Berger taught me Berger's point, and so that's where I really go for my surgical approaches on the distal ulna. I do have a conflict of interest. Some of the plates you'll see are developed by our working group, the hand expert group, and so the hook plate and some of the other plates. So we've got a whole new bunch that are in the design phase right now for working on the distal ulna. But locked plating has been the real key for me to get the distal ulna stable, and I'm amazed at how small plates that we can use and still get good stability. But the distal radius, the end game, has been espoused by people like Doug Hanel and Hans Kreter, and it's really the radial angle, palmar tilt, ulnar variance. You all know those, and if you achieve those by whatever means possible, you end up with a fairly stable distal radius that is pretty functional, and you get good results. The problem is we don't have that same predictability for any kind of radiographic parameters of the distal ulna, except maybe length relationships between the radius and ulna. So that's something we need to work on. And since I retired in January, I'm leaving that to the next generation of hand surgeons to sort through that. So ulnar column is real important. And I want to point out, if you guys can see my pointer here, I want to show this, the volar teardrop here that Bob Medoff really emphasized how much of a volar buttress that is. And that's why in supination, the distal radial ulnar joint is quite stable. Even 20 degrees of supination will start engaging that volar lip. And it comes down as a big volar buttress for the ulnar head. And so that's this has always got a big ligament there and a big articular surface. And so always remember, so goes the lunate fossa, so goes the sigmoid notch. They're inextricably linked together. So fractures of the lunate fossa are basically fractures of the sigmoid notch. The other thing I want to point out is how asymmetric the ulnar head is. And here's the palmar side, which has got great promise for plating, and you can put screws right across here and go underneath the ECU tendon. You do not want to go into the ECU tendon with any screw heads. Your hand therapist will hate you for the rest of this case. And I always say that if you fix the fracture well enough, the hand therapist likes it, then you've done a good job for both the patient and yourself. But the hand therapist is usually the final arbiter of what's good stability as they start cranking on these things. And so I'm really interested in hearing what Rachel's got to say about tricks of the trade. And so the palmar surface of the distal ulna is actually somewhat broad and flat, and you can get a two-hole locking plate on there pretty easy. The problem is that the ECU covers those dorsal surfaces, and the rest of it's articular, so you really can't put much up there without bothering that closely applied ECU tendon, which is incredibly important for TFCC stability. And then implants can impinge on the capsule, and you see that capsular bulge down there. You don't want to put your metal right up against that zone. So there's a safe zone in the distal ulna, a lot like the safe zone of the non-articular portion of the proximal radius. They actually are two just mirror images. And so the subcuboid of the distal ulna, so the ulnar styloid and the tip of the olecranon is the subcute border of the ulna. And so it's not an implant-friendly zone. You put an implant there, it bothers the dorsal sensory branch, the ulnar nerve, and every time the patient puts it down, they hate it when they feel the plate right there on the styloid. So it's not the best place. It's almost like an annuity. If you put an implant there, you're going to have to take it out. And so here's a thing out of the AO website, but it's really by Frank Beers out of Lucerne, who's really studied this a lot, and they've published on it. This is a consortium of guys from Utrecht and Lucerne and Basel, and they've really done a nice job of showing that safe zone of the distal ulna for where you can put plates with retraction of the ECU tendon where it does not integrate yet with the TFCC. And you see you've got the styloid, and you got the palmar side. The FCU falls away once you get but that's Berger's point, is right there on that palmar side where you can put your thumb right on the TFCC. So back in the day, we had these fixed angle devices, and that really revolutionized the distal radius. And then in the late 90s, we started getting some small fixed angle devices, a 2-4 blade plate here, and so we could start doing better fixation of these loose heads. Here's a case of mine from 1992. This is when I was an attending already, but this is a case I did as a fellow with Jim Steichen, God rest his soul. And as you can see, we didn't get the ulna quite long enough. It was already short, but we made it a little shorter. But with all the dissection in this big 2-0 plate just smothering the blood supply, you see that 8 years later, the ulnar head has died. And this was the one case that kind of woke me up. You can see it's an old 3-5 plate, both bone form fracture with very distal ulna. And I did this as a fellow with Jim, and that came back to haunt me 8 years later as an attending. But nowadays, there's a bunch of different implants that you can do that are both minimally invasive as well as maximally invasive. And you'll see the hook plate down here, which is our development. We let commercial partners manufacture these after the AO develops them. But here's a nice one where they're putting the plate on the palm side, but it wraps around and goes onto that right up to the styloid. And so actually many, many different plates will work. And I'm just amazed actually at how small the plates can be when you're talking about things distal to the central tendon or central ligament insertion. With that, I rest my case, and we'll take questions later. Thanks, everybody.
Thank you very much, Tom. Great points. Looking back at that, there was a question actually about osteolysis of fixation, and I wonder if maybe that distal ulna that you showed is an example of, do we call that osteolysis, or what is it exactly? Is it from dissection? Is it from metal? Is it from whatever? But someone had a question I answered, and I said, well, the only thing I could think of was maybe, is it us getting to it, or is it the piece just didn't like the metal in it, or I'm not quite sure. But fortunately, it's not too common. Have you had seen that very often, or any other cases, or is that the one?
No, I've seen a couple cases where the ulnar head just kind of melts away over time, and I never can tell if it's early osteoarthritic changes from exposure of the head, or did we dissect it way too much, because we didn't really understand all the blood supply of the distal ulna at the time. And so we got kind of carried away with going dorsal and volar on it. And so I'm not sure which combination of events, but I know it occurs, and I think respecting the blood supply and leaving the ECU closely applied to the TFCC and still anchoring the TFCC to the distal ulna is, for me, the secret to success.
Yeah, I always think if you look at the other end of the other bone, if you overdo it on the radial head, you might have the same problem, right? So, but interesting things. Thank you very much for all those points. That other plate looks kind of nice, the one volar and going around the side. So I think with that, we're going to go to the West Coast here. And Dr. Boe is going to go on from her experience at the University of Washington, Seattle, and Harborview. And take it away, Chelsea. You all set?
I think so. I'm just going to get this hopefully going here. Seeing slides okay?
Looking good.
Wonderful. All right. Well, thank you for inviting me to participate this evening and share with you some of the painful lessons I've learned treating these fractures. So this is going to be several cases highlighting some key takeaways that are going to reinforce some of the things that you've heard thus far from Dr. Dennison and Dr. Fischer. So my disclosures aren't relevant for this talk. We will start with an 87-year-old gentleman who fell at home. He lives independently. He's a retired attorney. He's extremely active despite his numeric age, so young physiologically, we'll say. These are his presenting films. So you can see this displaced fractures of his radius and ulna, the dorsal translation of his carpus relative to the radial shaft. And he was ultimately indicated for operative management given his displacement and his activity level. And so he was treated like this, with open reduction internal fixation of both the radius and ulna, with a locking plate that was a 2-0 plate from a handset. And that was, let's see, his initial fixation, but we'll go on to his follow-up images. So unfortunately, he developed some mild collapse of his ulnar head, some heterotopic bone around his distal ulna, and you can see these are sequential images from left to right, and these are spaced out by about a month or month and a half between these images. So he had persistently visible fracture lines, increasing heterotopic bone, but more importantly, this is what his soft tissue looked like. So he developed a breakdown over the prominent ulnar hardware with gross purulence and ultimately had an exposed implant at that ulnar wrist. So he ultimately got this as his treatment for his distal ulna fracture. So clearly not necessarily what we had intended. And going back to those initial films, I would obviously choose to treat this differently. There's an element of the Monday morning quarterback knowing what I know now. But if I go back to his intraoperative films, looking at after we've restored the alignment of the radius and then looking critically at the ulna and keeping in mind his age, which again, that's a whole nother conversation. But there was actually relative restoration of alignment of the ulna after fixation of the radius. It's not perfect. We haven't perfectly restored that coronal alignment, but it's something that I think in hindsight, I probably would have accepted. I look at some of these oblique views where you're looking at passive motion and seeing that overall the alignment of that ulna, I think is something that in hindsight was pretty acceptable. So the take home point here is that this is crucial. Not every fracture needs fixation. Like, don't be this YouTube video. It's not, if you don't fix the fracture, do not fix the fracture. There's supportive data that combined radius and ulna fractures, 5 centimeters from the ulnar head, can be treated conservatively in a population over 65, even when they're unstable, and when indicated as 10 degrees or greater of angular angulation and greater than 50% of translation, even with passive forearm motion. Moving on to another lesson, we'll say. So there's a 19-year-old male involved in an MVC. He had numerous injuries, including this right radial styloid and ulnar head fracture. Given his alignment on these initial films, he was splinted and treated conservatively. After about 4 weeks in a splint and then subsequently a cast, he developed progressive translation. And now you can see here on that lateral view that he's got greater than 50% translation as ulnar head, but more importantly, he had ongoing pain and limited rotation. And so then he was indicated for operative management, and we turned what would have been still a hard fracture, but an easier fracture in the acute setting into a much harder takedown of kind of a nascent malunion for this young patient. So I think overall we got good correction, completely restored his pronation supination, but this is one where we took home benign neglect doesn't always work. So you still have to look critically at these fractures, assess their stability, and recognize that you can't just treat these all in a cast. The non-union rate for these fractures can be as high as 12% with conservative management, and interestingly is not impacted by above or below elbow immobilization, according to a 2007 study. Keeping going with these cases, this is like cathartic. I'm airing dirty laundry here. So our next case is a 77-year-old male. He had a ground level fall, taking out his trash on his sloped driveway that was slick from some nice Seattle rain. So he sustained this open fracture. It was open volar ulnar. We treated this with management first of his radius. He had an IND of that open ulna fracture, and because of some persistent coronal malalignment, we elected to treat that ulnar fracture. But we didn't want to open that further because he already had the open fracture, was already at risk for non-union related to that. And so I elected to treat this percutaneously with pin fixation. And this is one where if you look at the obliques, we've been able to restore that overall alignment and avoided additional stripping of the fracture. So this was a case where hopefully I was learning my lesson about ignoring fractures. So we didn't ignore it, but we also didn't open it up and cause a further problem that I think Dr. Dennison was alluding to earlier. So he was immobilized in a short arm splint because short versus long doesn't matter in these fractures, and he went on to heal uneventfully without complication. So this is a case where the lesson is know your options. So there's a lot of fixation options for these fractures of the distal ulna, several of which have been already discussed. In my practice, I find the least invasive treatment that accomplishes the goal of restoring sufficient stability is generally the preferred option. We'll turn to next a 53-year-old female. So this is another Harborview polytrauma patient. She had 4 extremity injuries, including this right distal radius and extremely comminuted distal third ulna fracture. And on the other side, she had this nice matching set, so a little bit less severe, but she had similar fracture pattern on her contralateral side. So we took this patient to the operating room and we first fixed that radius on both sides, and then we assessed the ulna fractures. And on the image on your right, you can see this an extensively comminuted fracture. And from her initial films, I think it's reasonable to assume this is not going to be stable and would probably benefit from some fixation. But this X-ray probably really undersells the degree of comminution of this fracture. And so this was one where I really didn't want to open and try to put an implant, a plate on this fracture. And then if you look at the image on the left, you can see there's some angular malalignment. So I think this definitely would benefit. I would expect her to potentially have some rotational problems with this degree of malalignment. And so I elected to treat both of these with an intramedullary K-wire to provide some gross stability. So this is a technique I learned from Doug Hannell. And to be honest, as a fellow, when he was first talking to me about this, I was skeptical that it would provide sufficient stability. And yeah, in Dr. Hannell, I trust, and I did what he told me, and in 2 months, she had this incredibly robust healing. We treated her in short arm splints, which made her life so much better as a polytrauma patient with 4 extremities injury. And at 2 months after surgery, with this amount of healing, she had 70 degrees of pronation and supination on both sides. She had no DRUJ instability, no crepitus, no pain with her rotation. So there's biomechanical data, namely a JOT article by Collins et al. Out of McGill, that demonstrated that for the distal ulna, There was no clear advantage of locking versus non-locking fixation, and they actually concluded that lower stiffness implants may actually confer an advantage in appropriately indicated fractures. So yet another case of knowing your options. As was mentioned previously, the rate of hardware irritation with distally placed fixation is significant, secondary to that limited soft tissue envelope. And I think we also mentioned something about patients with soft tissue injury and wanting to avoid opening those fractures and further stripping fragments, which is something I should have been more thoughtful about with this next patient. So this is our last case today. I still have some nightmares about this one. This is a 23-year-old female who was attacked by dogs delivering packages. She sustained this open comminuted distal ulna fracture with significant soft tissue injury that you can appreciate from the soft tissue shadows here. And she had avulsions of her EDC tendons at the myotendinous junction. It was quite a mess initially. And so my partner took her for an initial debridement of this big open wound. And at the time placed lag screws in the large, more straightforward, lagged across this proximal fragment that you can see better on these films. But there was still this unstable distal component to this fracture. And, being the next person who was set to debride this patient and do some definitive fixation for her ulna, I looked at this fracture and I thought that there might be some bone at that distal ulna that I could get some sort of fixation into and span across this huge segment to try to get some good healing. And so I took her to the operating room and I tried to put this long 2-7 plate across to try to get some rigid stability. And I thought maybe I'd get a screw in that distal portion there and put it on the volar side where I know there's a little bit of real estate where I can sneak something in there. And unfortunately, when I went to go place this first screw, it drilled straight through a coronal split through that, straight through a sagittal split there. So there was absolutely no bone in that underneath that plate. So unfortunately, these fracture fragments have been extensively stripped secondary to the injury, multiple debridements, and then my hubris at attempting open fixation. So I resorted to thinking about relative stability, trying to get some of the larger fragments of bone to generally restore a tube, and then attempting some longitudinal stability with an intramedullary nail. So this construct is not what I was hoping for. One of my partners, I'm going to assume lovingly, described this as duct tape together. I would have to agree. But it was a situation where we were trying to not necessarily get obviously not primary healing, but even not necessarily healing, but really trying to think about, okay, maybe we can live to fight another day, get some healing and some consolidation of these fracture fragments and make an easier secondary surgery for this patient. So after several months, she does appear to be consolidating proximal and distal, and potentially definitely going on to non-union at that kind of middle third, distal third junction. Interestingly, she actually has no pain, and 60 degrees of pronation supination is continuing to rehab her other injuries. So my take home from this was, do not underestimate your opponent with these fractures. These can be incredibly challenging. The most poor combination can be extensive and underappreciated on radiographs. There are limited areas that it can accept fixation, and extensive stripping to accommodate rigid fixation may worsen rates of non-union. You should definitely be prepared with numerous strategies. So that is our conclusion here. Don't fix every fracture. Recognize the fractures that you do need to do something to fix. And when you're going to fix these fractures, have a good awareness of what implants are available, remembering that simple things can work well. Respect these fractures, that soft tissue envelope, the limited bony real estate, the underappreciated comminution, and the really poor bone quality, especially when you start talking about the elderly patients. And remember that risk of non-union with these fractures, and always keep that in your mind. Good AO principles. Thanks.
Super, Chelsea. I can guarantee you that we all have been there and learned some of those lessons along with you. And fortunately, your wisdom, that you now have greater wisdom. But it still won't keep you out of all the trouble. Things will still happen. So I feel like a really medieval old hand surgeon right now, because I still put a lot of people in a splint that limits their rotation because I thought it was better. So when do you use a longer splint or sugar tongue, or do you never?
I rarely do. I would say if I'm concerned about a ligamentous injury, then I will do a longer splint. But for something where I've got some relative stability with these longitudinal K-wires, I will put them in a short arm splint.
Sure. If you don't mind, Tom, I'm curious, what do you think? What sage advice do you have for us?
I put them in a sugar tongue post-op for about 4 to 5 days till I check their wound. With dog bites, are going to be changing it often, but I do it more for comfort than anything else. And I still use external fixators for those bad dog bites. Those are vicious wounds, and I'll put 2 pins in the fifth metacarpal, a series of pins in the proximal ulna, and then do a box frame over to the radius just to control rotation of the forearm. Just 2 pins in the radius and just make a 4-corner box. And X-fixes for those type of wounds, I think, are the easiest for the wound care people to get to the wound, and also give the most stability with the least amount of intervention. For these ones, you need to have multiple debridements. I never underestimate how bad those are.
Can I ask you a question since I have you as a captive audience? We were talking about not using X-fixes because we use internal X-fixes with bridge plates oftentimes instead of external fixators for distal radius. Do you think there's a role for something like that for a distal ulna?
Yeah, I think for the soft tissues, for dog bites there is, but for rest of distal ulnas, I think just minimally, you can do combination stuff, do a longitudinal pin, intermedullary pin, and then put a little 2-0 keeper plate on it, just an anti-glide plate, or some sort of buttress little plate. But orthogonal fixation's hard in the distal ulna because you don't have much. So an IM nail or an IM pin and a little keeper plate is sometimes helpful. But for these bad ones, and soft tissues are always beat up over there because the radius goes radially and dorsally, and the ulna sticks out through that palmar thin skin. So you get a lot of soft tissue damage in that area. And I always look at the ulnar nerve and the ulnar artery in these bad ones too.
Yeah, certainly common to see those. Well, thanks for the comments. I think the one thing I would share, we looked at some stuff about distal radius fractures and found that fortunately splinting a little bit longer and including the elbow didn't slow most people down very much. A couple of good articles about it. So you have to find your comfort zone. But I've gone to more of a paddle so it doesn't go above, but it still gives them some support. And I think some of the colleagues that we fixed who were orthopedic surgeons who had distal radius injuries kind of said their ulnar side hurt a bit. So the take home for that for me was, well, maybe we'll give you something that doesn't spin. Maybe you'll be more comfortable, but certainly an interesting thing. But the end of the case, we're always putting something on, right? So with that,
yeah, I really like bivalve splints for these forearm injuries. If you get and run it pretty far up the forearm, and the therapist makes a nice broad proximal piece dorsally and palmarly, it really restricts motion to about maybe 20 degrees or so, and people can still wiggle in them. And it gives them good soft tissue support as well as restricts their motion without going above the elbow. We use a lot of Munster type splints, just
sure.
bicondylar weight, bearing on the condyles. But bivalve splints are my favorite.
Well, there's a perfect segue into Rachel Pigott's going to join us now. She is an occupational therapist and also the hand therapy fellowship director at Johns Hopkins. And take it away, Rachel.
Thanks. All right, here we go. Let's talk about the rehab of these injuries. Does everything look good on the screen there, everyone?
Yes.
Yes.
Yeah. Okay, great. Perfect. So I have no disclosures whatsoever, unfortunately. So globally, when I'm talking about the distal ulna fractures, what I wanted to kind of touch on was I guess tenets that I feel like are maybe the most important when you're considering rehabbing this population. So progressing like any other fracture, according to fracture healing, and having good communication with the physician. With these fractures, is there an associated DRUJ instability? And then that goes back to kind of like the discussion we were having about short arm versus, like Munster or something like that controls the rotation a little bit. What impact does the scar or the hardware on that ulnar side, given there's not much soft tissue protection over there, what kind of impact does that have on the patient, and how are you going to adjust your plan of care, considering if there's any irritation with the ulnar nerve, and then always with any wrist injury, I'm thinking about proprioception. So just in general, when we talk about fracture healing progression, generalities, you're progressing from active passive to strength. And generally you progress every couple of weeks with each step, as long as there's appropriate fracture healing, unless there's something going on, a more severe fracture where it's taken quite a bit of time. And maybe starting around 4 weeks, if it's not a fracture that has, with active motion, if it's not a fracture that has any sort of instability associated with it, that is going to like demand that there's a little bit longer immobilization if you have any sort of instability, especially with the DRUJ. You might start moving a little bit earlier if it's a less severe fracture and there's some sort of rigid fixation. So these are the kind of orthotics that I would be choosing. And so the orthotics on the right are the Munster type braces. So they're going to control rotation a little bit more. One of them is more radially based, and then it kind of like hugs the condyles of the humerus. And then you have the one a little bit further down that's posterior. So they both do a good job. A lot of the times I make my decisions depending on what seems to hold the patient a little bit better. With a bigger arm, I might actually choose the posterior one because it holds their arm a little bit more, and I might have it come a little higher on the sides and change my decision making with straps. If you don't have issues with stability of the DRUJ, they could be in a wrist orthosis. So you just have a couple of versions of this here. I would probably actually make it a little bit longer than the ulnar gutter version of the wrist orthosis that you see there, a little bit further up on the arm if it was for a distal ulna. And then when they're starting to move and they need less protection for the healing fracture, a lot of the times I'm using soft tissue supports just to provide a little comfort to the patient. So that's what you see on the right. That's something you're going to be using later when things are healed. So you see a wrist widget. It just provides a little space there between the carpus and the ulnar head. The one with the circle is called a bullseye. And then sometimes I also use taping. So this is kinesio tape, is the pink and black, just supporting the ulna side of the wrist. There's a couple of different techniques there. And then the other taping up here is something called a dynamic tape, the one that looks a little bit like a tattoo. And I have it on the radial side of the wrist. So I do that sometimes if they're having issues with ulnar-sided pain to discourage them from resting down into ulnar deviation. And sometimes that really helps with pain with that. Skip a slide there. So a lot of the times you might have stiffness if your patient needed to have immobilization for a longer period of time. And there are some different solutions for stiffness. A lot of the times, you know, we try passive motion, it's not really working. I'll do some mobilizations. A lot of the times joint mobilizations is the proximal radial ulnar joint to gain some motion down at the wrist. I'm not a big fan of doing DRUJ mobilizations. But then I also might use a static progressive orthosis. So in this slide, you see a prefab for forearm rotation. That's on the left. You see a custom static progressive orthosis for forearm rotation that is in the middle there. And then the other ones are custom orthotics for static progressive for wrist flexion and extension, depending on what the needs are of the patient. So I had pictures of prefab and also custom, just because sometimes insurances don't pay for these orthoses and they can be very expensive. The other thing I'm thinking about in the back of my head when I'm taking care of these patients is that ulnar nerve is over on that side of the wrist. So sometimes even the best surgery, the scar and the lack of soft tissue over there, sometimes the scarring will grab the ulnar nerve. And so I work really diligently with the scar, but I might also do some things to try to work on hypersensitivity or nerve gliding to try to address any issues with the ulnar nerve over there on that side of the wrist. So what are some things I do for scars? So what you see there on the left is a style of kinesio taping where it's like crisscrossing. So it creates different forces in different directions. And when the person moves, it really does a nice job of loosening the scar. You see a gel sheet, which is something a little bit more traditional. And then also, I'm always thinking about proprioception. With any wrist injury, I'm always thinking about proprioception. Going back to like the fact that a lot of the times they're soft tissue injuries. Even if there's not instability, I know those structures were stressed with some of these fractures, so I'm always considering it. So this is an example of a joint position test that's standardized for wrist, but it tests wrist flexion and extension. So it's been tested for minimally detectable change and minimally clinically important differences in distal radius fractures. But when you look at, so this is not exactly distal ulna fractures, but I start to think about the DRUJ when I think about the distal ulna. So this is a study where they looked at injuries to the deep fibers of the PRUL and DRUL of the TFCC. And they tested proprioception with a really interesting sounding device. It's a inertial measurement device that had 9 axes of rotation. And they tested accuracy of joint position sense with wrist flexion, extension, ulnar radial deviation, pronation, supination. And the only ones where there was a significant deficit was with pronation and supination. So it just makes me kind of think, perhaps we should think about people that are having these ulnar-sided wrist issues, that we should come up with easy to do in clinic test, much like the joint position test I showed earlier, that's measuring pronation and supination. So we can kind of evaluate that in clinic without a fancy 9-axis inertial measurement device. Anyway, so how do I work on proprioception if I see a deficit? So there's a lot of different things. So I'll work on joint position sense. So you see here, they're just trying to like get to the target of the range of motion I want them to get to. There's a variety of apps on the phone. A lot of times I'll have them hold a Frisbee or a cup or something and try to move something around in it and control it. I'm also working on dynamic stabilization for these injuries, where I work on activation of pronator quadratus, and that's what you see in this picture with the pen. And I do it really lightly, submaximal isometrics. I find it's really helpful, especially like in early phase of rehab. And then a lot of the times you might have an injury where there is delayed healing, and I'm an impatient person, so I'm always chomping at the bit. And I find a lot of the times the patients are, because they're really held still and they're wanting to do more. So sometimes there's certain things that can be really engaging for them that makes them feel like they're not losing as much by being immobilized as long. My first tip is, when they can start doing light things, encouraging them to do light functional things and giving them an example of what that is, what's safe and what's not. That way they don't make a bad choice. Surface EMG, I really love, especially if they've been immobilized for a long time. They have a hard time accurately activating the wrist extensors and flexors, and it's really kind of fun and engaging that you can do there. You can also have it connected with NMES that augments their strength. And I love BFR when people are in a phase where they can't stress the fracture, but you want to like keep them engaged and have them be able to work on strength. BFR will work on not losing strength with a completely non-resistive exercise. So it's a really good application as long as there's no contraindications. And then when I do progress to strength, I always make it functional. I do like to do a lot of stabilization kind of things. So you see here, I use the TheraFlex bar where I'm pushing in different directions and work on them maintaining that stable wrist position for strengthening. So that's everything I have. And with a picture of a cute kid and a dog. Everybody loves that.
Thank you very much, Rachel.
Yep.
Well, hopefully we got through the majority of our initial stuff, and we have a few other things planned for you. Any other comments from the faculty for the so far? Thank
Rachel,
you for answering the questions too.
Rachel, I actually like just a hammer. You know, you can choke up on a framing hammer or just a lightweight 16-ounce hammer, and just let them just oscillate back and forth to get their proprioception going and activate their forearm muscles. And you just give them an 8-ounce can to do that with just some eccentric weight. And it really does a nice job. Just have them sit their hand or their forearm on their leg, or just a light wrist curl in a zero position over the end of the table. And you can still keep stability and still activate some muscles with just an 8-ounce weight or a small hammer and just some oscillations. So I think activating muscle is a real important early kind of step in the rehab process if you like your stability.
Well, and I like those examples too, because so I had some fun, fancy things that maybe are just in the clinic, like BFR, surface EMG, but all of those things are things that they have at home. So that helps with adherence.
Yeah, we have a lot of hammers in the Midwest, so. Then they bring it in and they threaten their doctor with it. That's the bad part.
So I had a question, if you don't mind. Been fortunate enough to have only a couple of synostoses that occurred, some with and some without operating on the distal ulna, depending upon how bad that injury was across the distal interosseous space or membrane. And but sometimes we do have stiffness that's a little more pronounced, whether it's from casting and mobilizing the injury, maybe the patient wasn't able to do enough, they didn't take the splint up, whatever it is. So I'm just curious, in your experience, how often have you ever had to do any form of a capsular release to restore form rotation? I find those cases very unpredictable, and sort of, you hope you can get it to go well enough without having to operate on it, in my opinion, assuming that forearm access is okay and everything else. Is that something that you've seen rarely, or is there any tips or tricks related to that problem?
Yeah, I've seen it not often, but Bill Kleiman described a silhouette capsulotomy, preserving the TFCC inferior limb and just opening up that palmar capsule, and I find that a incredibly satisfying operation if the rest of the forearm axis anatomy is normal, and you don't have a nascent HO growing in the middle of the forearm, and your axial alignment is correct. So for those cases that are 6 months to a year out, they still don't have their supination. Palmar capsular release of the DREJ capsule really is a great little operation that frees the forearm up and gets them moving again.
Yeah, because we're all happy when they move nicely. There's, it's great, and then there's like the, oh well, somebody's,
every once in a while.
Yeah, not too often, but sorry, Chelsea, did you have a question or a comment? Nope. Okay. Well, we have a couple minutes, so if it's all right, I had a case or two or a couple of comments and maybe a case or two. I'm going to try to share my screen again. Hopefully this will work. Apologize ahead of time.
Has this been just clear as mud to the rest of the 153 participants?
Well, we've had a few questions, but not too many. Let's see. I am still having this trouble again. I'm going to close this one.
The TFCC is the size of a postage stamp, and the distal ulna is not much bigger, so it's a small piece of real estate we're talking about today.
Okay. Can everybody see that arrow?
Yeah.
Looks good.
Great. Okay.
Just follow it.
Yeah, that's the trick, right? Just like MapQuest, you follow the blue line. So I was just going to add, we did a study on these when we initially had these small plates come out, and just trying to figure out, like, well, where could we do it? And you could see, like, I wish I met Tom when I was interviewing for fellowship, but I wish I had spent more time with him then and figured out where to put these plates a little bit. But the you can see on the left side here, this was kind of distal, and I wasn't sure if I'd even get 2 pegs in, and trying to wrap it around the corner of the styloid seemed hard. So I just went palmar, not dorsal. And again, trying to make sure I didn't go out the sulcus. Usually you can tell by your depth gauge or your drill, but you can also, you can almost you could probably fluoro it a little bit and try to see if you're out. But again, the extra length probably isn't going to help you as much as, just like in the radius, probably having a 75% peg is about as good as you're going to get anyway. So you really don't have to go for the extra millimeter or two. It's really more of getting probably the plate where it might work for you. So fortunately, that patient didn't have any restriction or rotation with that, and it helped stabilize that distal ulna. The one on the right here was similar, but more of an ulnar directly off the styloid side for fixation. I did that on purpose to help bring or technically push the distal ulna radial, because it was kind of sitting in this hole and I was trying to pull it out. And if you're trying to do this, it's sometimes hard to hold the shaft where you want it to be relative to the distal ulna. And if you can get something in the distal ulna and then just put one screw in the plate, it works just like you would on a radial pin plate to help correct that coronal plane. You get your own little jack by just bringing the screw in. So as long as you're close, if you can't, instead of putting a giant forcep around the ulna and trying to hold the plate on, I just kind of put it close, and I get close enough, and I drill one hole and put the screw in. And fortunately, you can see which one I put in first, the long one here, because that was off the bone a little bit the first time. And I've got a few other holes that I can adjust if I'm off, but that can really help get your reduction without over dissecting the distal ulna. You really just have a window of 8 millimeters or so that's exposed on that side, just staying palmar to the ECU in particular. And I agree, those little plates, those are all 2 millimeter plates that I did those with. Just another little tip. I used to get tired of like, am I too distal? Am I far? How distal can I go? And I got to the point of just slipping a K-wire in over the distal ulna and just letting the plate go up to the distal K-wire. And then I was in the ballpark pretty much. And that helped me keep them not too distal. There is a little bit of a recurve back on the backside of the styloid right here. And if you can keep the plate in that, it's a little less prominent than if you roll way up on top of it. So it's kind of just the right amount, I suppose. In that series, we had a low rate of taking plates out, fortunately. I also that was a little bit of a small series. That's my series, like me doing everything. So hopefully I was unbiased about the results. But fortunately, I didn't take too many out. David Ring's study didn't have too many that had to come out either. But certainly it's more likely if it's sitting there irritating the nerve. So I would say, just out of interest, though, I kind of blew that. I was going to leave it there, but sometimes the distal ulnar fracture is a distal ulnar fracture with an ulnar fracture with a radius fracture with something else. So you have to be kind of like, okay, what order are we going to do this? And that may be beyond the scope of our talk here, but I would say, to everybody, probably I would just start, putting Humpty Dumpty back together here and stabilizing this. This was a case that one of our fellows called me and was like, do you want to do the rest of this? And we'll, take care of the immediate part tonight. And that's what they did. And they fixed the ulna, did a nice job with that, and fixed this. And then I was able to come back, and the radius is a whole nother, topic here. But the interesting thing here was the teardrop's off. You can see the marginal fragment. So we got that back together, fixed the ulna. And I chose to do that in 2 plates. I thought doing it in one would be tricky. And it would, seem like enough of a bridge in between. And with a small plate, maybe a little less stress shielding down there, but worked out pretty well. But if you do have maybe say you have a comminuted fracture here and you are going to fix it, I've gone to some of the Acumed system, in particular using intramedullary nails, and we've gone from the olecranon all the way to the styloid in some cases. That was pretty interesting to drill a 6 millimeter hole in the proximal olecranon, but once you get past that, it's an interesting way to go. If you have to go the opposite way as well, it doesn't hold it perfect, right? But it's enough to, I didn't do an incision from the styloid to the olecranon either. So sometimes these things find you and you need a little solution. These are just a couple of old cases that I had. This guy on the right ripped his thumb off, so we did a thumb replant. I fixed his radius quickly and probably could have used a smaller plate. I think it was before I was comfortable using the tiny plates that we can use for the distal ulna. Worked okay. He never came back. I never took that plate out. This was a smaller female patient, and we didn't really have some of the nicer plates you have now. So we did a 2-7 and just allowed a few more bites. But the idea with this was that sometimes if you are looking at a longer area of comminution and it's reasonable to fix the whole thing, a straight wrist fusion plate can be a nice plate to get a few bites in the distal part, and then you can use your plate, for the more normal part proximally. And that also works on the proximal radius flipped around. So it's a nice little tip. I found that helpful. I think Alex Shin probably taught me that, and I've used it extensively on the proximal radius as well. And then I was just going to add this one other little thing for those who maybe don't use this technique. I love this view. It's not so much for the skyline, but if you are working around the sigmoid notch and you're trying to make sure that your implant, whether it's in the ulna or the radius, is looking pretty good. It's not perfect, but you can get about 30 degrees off axis and you can get a reasonable look at your sigmoid notch. And I would encourage you to use it for your radius fractures in particular, and make sure, you kind of look and that ulnar peg's probably fine. You want to feel better about it. It's not a bad way to look at it. You can also get a view of the dorsal ulnar reduction as well as the volar ulnar reduction here. So maybe a little bit, not as great for the ulna, but certainly a good sigmoid notch trick. So I think any other comments? Otherwise, I think we're a few minutes early. We have any other questions? I didn't thank you for answering them along the way. I think otherwise our summary for this was to understand the injury through the x-ray, maybe additional CT, and that you a lot of what we're going to do is dependent on an intraoperative examination of the DRUJ and the stability. Consider the coronal plane reduction of the radius and ulna, in addition, of course, to the length of these and the sagittal plane reduction and rotation. Try to limit the dissection if you can. Hopefully, some of the tips we've reviewed can you can use for get to where you need to be for an implant or for reduction, and but try to preserve blood supply as much as possible. Careful use of implants, and I think when you're done, if you have a reasonable DRUJ, you've achieved your goal, and that's really the end point right there. So, any other closing comments from everybody? I wanted to, while everybody's getting any final thoughts together, I would like to sincerely thank everybody at the at AO for their help tonight, and Tom for joining us tonight, as well as Dr. Boe and Rachel coming from the East Coast, or it's a little later. We appreciate your time and all the time you put into our discussion tonight. And certainly, please make sure you can access the video if you didn't get a chance to see the whole thing. And I think I'll speak for all of us and say we'd probably all be happy to answer any questions right now if you have something in the Q&A, or even reach out to us if you'd like afterwards. So,
just one technical point, Dave. The radial column plate, which kind of shoves everything ulnarly, it's a great buttress device for if you're having trouble getting that coronal translation out of your construct. It's good for holding up the radial styloid. It's better than a pin over there for that translation. So I'm a big fan of Rickley and Regazzoni and Bob Medoff really were the early pioneers in demonstrating the effectiveness of that plate put on the radial column. It's easy to put on. You can do it from the dorsal approach or the palmar approach, and don't be afraid of the first dorsal compartment. It raises right up, and you just plate over the top of the insertion of the brachioradialis, because brachioradialis is actually the floor of the first dorsal compartment. So that's a way of releasing the VR and putting a plate on there to shove it over and really fine tune that ulnar translation.
Sure. I think, the other two tips for that, they're a little less. If you don't have that styloid exposure, I have gone to using a point of reduction forcep, and I can get it on the ulnar side of the metaphysis, and I can kind of creep it over the styloid. And if I can't do it by myself, or lifting the metaphysis, that's pretty nice. And then there's a third one that I don't like to use, but I do see it talked about a little bit, is basically putting something between the radius and the ulna and spreading it apart like a small lamina spreader. I don't like to dissect the pronator quite so much there, but a couple of tips that if you're if you're not able to go to the styloid, or you don't want to, or maybe your incision isn't perfect for additional incision, I would say for my volar plates, I don't know if you do, Tom, but my distal limb of my volar plate incision is always radial. I don't know if everybody else does that, but it allows me a little bit of in case I need it, room. And that any other tips for getting the styloid plate on, especially if you are going to use a volar plate?
I'm a big fan of the lamina spreader between the two. And what's interesting, when I've gone back and taken out HO, it doesn't seem to involve the pronator. It's actually seems to involve the interosseous membrane. Right. And I've yet to see a big HO in the distal forearm that's got some sort of muscle in it that seems to be the generator. I don't know. How about you, Chelsea? You've seen a lot of HO from looks of those X-rays.
I haven't. I'm very unafraid to put something between the radius and ulna, because I think sometimes that is an extremely helpful way to get that challenging coronal reduction in some of these fractures. There's also some devices that you can use that are like essentially flexion distraction type devices that can allow you to kind of distract and then rotate and get some of that coronal reduction. I will also sometimes grab with a lobster and do a combination of those two. Those can be challenging reductions, and I think knowing several ways to accomplish that sometimes is really helpful. And I have not.
Yeah, if you take your lamina spreaders and grind off the tips, they seem to be a little less traumatic, but they pop out easy.
Have a
you guys, I have to say that I've certainly had been in the situation where I've tried to get the reduction, and I'm close, but I know it's off a little bit, and then I've gotten a little bit fancy and put the plate on, but I let the proximal edge of the plate hinge off a little bit so that I could then just kind of spin it back. Sometimes if that's another little trick, if you're close, I find that helpful for osteotomies. But
Swing it.
yeah, great. Yeah, swing it. Yeah, rotate it, right? Just a little bit, and you can put your clamp on or just drill your hole eccentrically and get a couple more degrees. So great tips, great discussion. We probably should wrap it up. I appreciate everybody's time tonight and for the emails, discussion, and everybody's support at AO, and also to everybody else who's out there, either working, residents, fellows, and we all thank you for your time tonight away from family and everything else. And we'll conclude here. Thank you very much.
Good night.
Thanks so much. Have a good night.
Good night.